Today's class is on extraocular muscles. What are the contents of orbit? There is
eyeball.
Eyeball is present. That is the most important content. Then
Muscle.
what are the muscles?
Uh,
There are voluntary muscles and involuntary muscles that we'll be seeing now. Okay. And then what are other contents?
nerves are there.
So what are the nerves that we see in the orbit?
Optic, oculomotor, trochlear, abducent, ophthalmic, and ciliary ganglion.
Yes. So optic nerve is seen, that is emerging from the eyeball. Then we see the nerves that supply the extraocular muscles and move the eyeball. So that is the oculomotor nerve and trochlear nerve and abducent nerve. Then you have the three divisions of the ophthalmic nerve, and the three divisions of the ophthalmic nerve are
lacrimal nerve, frontal nerve, and nasociliary nerve.
Yeah, nasociliary nerve. So these are three divisions of the ophthalmic nerve. Okay, so we have the eyeball, we have the muscles we saw, then there are nerves we saw. Then what are other structures that are seen in the orbit? Other contents of the orbit?
Ophthalmic artery.
There is ophthalmic artery. Then, and the branches of ophthalmic artery. Then,
ophthalmic vein.
so which are the ophthalmic veins? So there are two veins, superior ophthalmic vein and inferior ophthalmic veins. Both are draining into the tributaries of
Cavernous sinus.
cavernous sinus. Yes. So they are draining into the cavernous sinus. So these are the veins. Then any other structure within the orbit? Any other content of the orbit?
Lacrimal gland.
Yes, very good. Lacrimal gland is present. So these are the contents that are seen within the orbit. Today's class is on the extraocular muscles. Okay. So like we said, there are voluntary muscles and there are involuntary muscles. So we look at the voluntary muscles first. So how many voluntary muscles are there? Number? 7. There are 7 voluntary muscles. So there are 4 recti muscles, 2 oblique muscles, and there is one muscle that moves the upper eyelid. So what are the muscles? There is the superior rectus, the inferior rectus, lateral rectus, and medial rectus. They are the recti muscles. And then you have the 2 oblique muscles, that is superior oblique and inferior oblique. So total 6 muscles that move the eyeball, plus 1 that moves the upper eyelid. And that muscle is called levator palpebrae superioris. Okay. So we have to see each in detail. And what about the involuntary muscles? There are 3 muscles which are involuntary muscles, and these are the superior tarsal muscle, inferior tarsal muscle, and there is a muscle that is called orbitalis. Okay, so the superior tarsal muscle is also known as Muller's muscle, and it is actually a part of levator palpebrae superioris. So the voluntary muscles are supplied by 3, 4, and 6 cranial nerves, whereas the involuntary muscles are supplied by the sympathetic system. Okay, so first we look at the voluntary muscles. Okay, so we look at the 4 recti muscles. When you study any muscle, we have to know the origin, insertion, nerve supply, and action. So we look at the origin, insertion first, and the nerve supply and action will look in the end together. Okay, so recti muscles, there are 4 recti muscles. This is the which muscle? This is medial wall of orbit. So this is which muscle? Medial rectus. This is the lateral rectus. This muscle is superior rectus. And this muscle is
Inferior rectus.
inferior rectus. Yes, inferior rectus. So these muscles you can see having a common origin from a ring. And what is that ring called? What is
Common tendinous ring.
Common tendinous ring called common tendinous ring of ZINN. So you have all these 4 recti muscles are taking origin from the common tendinous ring of ZINN. This is the common tendinous ring of ZINN, which divides the superior orbital fissure into 3 compartments. Okay, so this common tendinous ring of ZINN encloses the intermediate part of superior orbital fissure and the optic canal. Okay, this is the optic canal. So this is the common tendinous ring of ZINN. And we should know the origin of each of the recti muscles. So this muscle is which muscle? The origin of? This is the superior rectus muscle. All the recti muscles are taking origin from the common tendinous ring. So this is the superior rectus muscle. This is the
medial rectus.
Yes, very good. This is medial rectus. This is
inferior
rectus.
And this is the
lateral
rectus. Okay, so lateral rectus, you can see it is taking origin by 2 heads from this ring itself, but it is taking origin by 2 heads. Okay, 2 heads of origin for lateral rectus. So you have all the recti muscles. And which is this muscle that is taking origin from this bone? Which is this bone? So this is the lesser wing, this is the greater wing, and this is the body of sphenoid. And from the undersurface of lesser wing, you have two muscles taking origin. That is above the common tendinous ring, there are two muscles taking origin. Which is this muscle above this?
Levator pulp.
Yeah, this is the levator palpebrae superioris. And this muscle which is taking origin from the undersurface of lesser wing, but medially. And that muscle is?
Superior oblique muscle.
So you have the four recti muscles taking origin from the common tendinous ring, and above that, from the undersurface of lesser wing, you have two muscles. Above it is levator palpebrae superioris, and above and medially it is superior oblique muscle. Is it clear? The origin of the recti muscles. Now we look at the insertion of the recti muscles. So tell me the insertion of the recti muscles. It is inserted onto the
Sclera.
It is inserted onto the sclera in front of the equator. So if you imagine, this is the eyeball and this is the equator of the eyeball. Okay. So in front of the equator, you get the insertion of all the four recti muscles. So it is behind the sclerocorneal junction. This is the sclerocorneal junction. Junction of sclera and cornea. Behind the sclerocorneal junction, you have the insertion of the recti muscle. So this you should know. The medial rectus is inserted 5 millimeters behind the sclerocorneal junction. There is difference in the insertion, point of insertion. So medial rectus is inserted 5 millimeters behind the sclerocorneal junction. Okay. Inferior rectus is inserted 6 millimeters behind the sclerocorneal junction. Lateral rectus is inserted 7 millimeters behind the sclerocorneal junction. And superior rectus is inserted 8 millimeters behind the sclerocorneal junction. Is it clear? So all the recti muscles are not of equal length. Which is the shortest muscle?
Superior rectus.
Superior rectus is the shortest muscle and medial rectus is the longest muscle. Okay, but all these four recti muscles are inserted in front of the equator onto the sclera. So now we'll see the oblique muscles. So there are two oblique muscles, superior oblique and inferior oblique. Which is this muscle arising from the undersurface of this bone, lesser wing, and then passing forwards, and then it is becoming a tendinous structure. It is changing its direction around a fibrous pulley that is attached to the trochlear fossa and getting inserted onto the sclera. Which is this muscle?
Superior oblique muscle.
So what is the origin of superior oblique muscle? From the undersurface of lesser wing of sphenoid, above and medial to the common tendinous ring. Okay, from the undersurface of lesser wing of sphenoid. So here you will get the lesser wing of sphenoid. This is a part of lesser wing of sphenoid. So in this side also you will get. So it is taking origin from undersurface of the lesser wing of sphenoid above the common tendinous ring. And it is passing forwards along the upper border of medial rectus. Here you will get the medial rectus. So along the upper border of medial rectus. Then why do you need this fibrous pulley? Fibrous pulley helps in changing the direction. Then the muscle passes backwards and laterally, and it is inserted from the sclera but behind the equator. So recti muscles are inserted in front of the equator, and oblique muscles are inserted onto the sclera itself but behind the equator. So this is where you get the origin of superior oblique. Okay, that is above and medial to the common tendinous ring, and from the undersurface of the lesser wing of sphenoid. That is the origin, and this is the site where it changes direction. This is the fibrous pulley that is attached to a fossa here. That fossa is called
Trochlear
fossa, and it changes direction. Then it passes underneath the superior rectus muscle. This is the superior rectus muscle. It passes underneath the superior rectus muscle, and it is inserted onto the sclera behind the equator. And which quadrant? It is to the postero-superior quadrant. So if you divide this eyeball into 4 quadrants, this is the postero-superior quadrant. Postero-superior quadrant. Okay. So that is the origin and insertion of superior oblique muscle. Now we have to see the
Inferior oblique.
So this is the inferior oblique muscle, right? This is the inferior oblique muscle. So where is it taking origin from? Which is this bone?
orbital surface of maxilla.
It is the orbital surface of maxilla. And which part of the orbit? So it is taking origin from the orbital surface of maxilla, from the floor of orbit. Then it is passing backwards and laterally and upwards below the inferior rectus muscle. Then it passes deep to rectus muscle, and here also it is inserted onto the sclera behind the equator onto the posterior superior. So both superior oblique and inferior oblique are inserted under the posterior superior quadrant. Okay, so that is the origin and insertion of inferior oblique muscle. Okay, now we look at the nerve supply. Which are the nerves that are supplying all these muscles?
Oculomotor, abducent,
So these three nerves, 3, 4, and 6 are concerned with the supply of the extraocular muscles. How are these three nerves reaching the orbit?
superior orbital fissure,
What is this green structure?
common tendinous ring of SINN,
So this is the superior orbital fissure. This is the optic canal. This is the optic canal. And what are the structures passing through the optic canal? What is this?
ophthalmic artery,
Okay. Then you have three compartments. There is a supralateral compartment, there is an intermediate compartment, and inferior compartment for the superior orbital fissure. So this is lateral, this is medial. So tell me what are the structures passing through the supralateral compartment? LFT on a eye. Do you remember this code? LFT on a eye.
yes ma'am,
So LFT is going to pass through the supralateral part. So what is the L? What is L? L?
lacrimal nerve,
Lacrimal nerve. F is?
Frontal
nerve. T is? Trochlear nerve. Then O, N, and A is passing through the intermediate compartment. So what is O?
Oculomotor nerve.
Oculomotor nerve has got a superior ramus and inferior ramus. So that is both are going to pass through the intermediate compartment. Then you have N. What is N? And what is A?
Abducent nerve.
And what is I?
inferior
Ophthalmic vein.
So I is inferior ophthalmic vein. And so if there is inferior ophthalmic vein over here, in this compartment, supralateral compartment, there will be superior ophthalmic vein. And there is an artery. What is that artery? Recurrent meningeal branch of lacrimal artery. Meningeal branch meninges supply am. So recurrent meningeal branch of lacrimal artery. Okay. So these are the structures that are passing through the superior orbital fissure. Superior orbital fissure can be asked as a short note. So you have to draw all these diagrams. What about the muscles that is taking origin from the common tendinous ring? Which is this muscle?
superior rectus,
This is superior rectus. This will be rectus. This will be
Inferior rectus.
This will be inferior rectus. And you have
lateral rectus,
lateral rectus has got two heads. And between those two heads, this abducent nerve is passing. Above the superior rectus, you have the origin of the levator palpebrae superioris, and above and medially you have the origin of
superior oblique muscle,
oblique muscle. And what about inferior oblique? On the floor of orbit, right? On the orbital surface of maxilla. Which is now
trochlear nerve,
this is trochlear nerve, and this is the
abducent nerve,
abducent nerve is supplying which muscle? This is which muscle? This is the lateral. Trochlear nerve supplies superior oblique muscle. Okay, superior oblique alone is supplied by the trochlear nerve, and you can see this is the oculomotor nerve, and you can see the two divisions of oculomotor nerve. So the upper division of oculomotor nerve is going to supply which all muscles? Which is this muscle?
superior
This is the superior rectus, and this is the above that. Which muscle is this? Going by
levator palpebrae,
this is the levator palpebrae. So the upper division of oculomotor nerve supplies the superior rectus, and then it supplies the levator palpebrae superioris. And you can see this is the lower division of oculomotor nerve, and that is going to supply. This is which muscle?
inferior rectus,
This is the inferior rectus. This is which muscle? Inferior oblique. And this is which muscle?
medial rectus,
So three muscles are supplied by the inferior division. That is inferior rectus, inferior oblique, and medial rectus are supplied by the lower division of oculomotor nerve. So most of the muscles of the eyeball are supplied by, most of these muscles are supplied by the oculomotor nerve, except the lateral rectus, which is supplied by the abducent nerve, and the superior oblique, which is supplied by the
trochlear nerve,
You have the 3, 4, and 6 cranial nerves, and how will you remember this? LR6, SO4, remaining thrice. Okay, LR6 is lateral rectus is by 6th nerve, SO4 is superior oblique is by the 4th nerve, trochlear nerve, and the remaining is all the other muscles is supplied by the oculomotor nerve. This you can remember like a chemical formula. Okay, LR6SO4 remaining thrice. Now we look at the actions. So what will be the actions of the eyeball? So I'm drawing one eyeball over here. Think of your right eyeball. So what all will be the action? You can elevate your eyeball. Elevation. So one action is elevation. Then the second action is
Depression.
so you can depress your eyeball. Then what is this action? That is towards the nose. If you are going to move your eyeball, your right eyeball towards the nose, what is that action called? Towards the midline.
Adduction.
That is called adduction. Very good.
Adduction.
And if you're moving the eyeball away from the nose, laterally,
Abduction.
that is called abduction. Very good. And what are the other two more actions are there for the eyeball? So for that, also look at this diagram. This is the 12 o'clock position of the cornea. Okay, you are going to rotate your eyeball in such a way that the 12 o'clock position is moving inwards. Okay, medially, it is moving inwards. That movement is intorsion. What is it called?
Indoors.
It is called intorsion. Okay, torsion means rotatory. Okay, so intorsion. How is it? The 12 o'clock position should move inwards. That is intorsion. You cannot do intorsion of both the eyeballs together. The actions are said in terms of one eyeball only. If you think about your right eyeball and the 12 o'clock position is moving inwards, that movement is called intorsion. And if the 12 o'clock position is moving outwards, that movement is called
Extortion.
okay. So these are the 6 movements of the eyeball. So what are the movements?
Elevation, depression, abduction, and adduction.
Abduction, intorsion, extortion.
Yes, okay. Now we have to see which all muscles are producing each movement. Okay, so again we are talking in with respect to one eyeball only. Okay, this is the right eye. Okay, and this is your nose. So this is the medial aspect, and this is your eyeball. Okay, so this is the lateral aspect. Okay, we're looking at this diagram. Okay, so we are going to write the names of the muscles. This is a diagram for you to remember the actions correctly. If the labeling of the diagram goes wrong, the actions will go wrong. Okay, so you have to write the superior rectus over here. You have to write the medial rectus over here. You have to write the inferior rectus over here. And we will write the inferior oblique over here and superior oblique over here. In the medial aspect, you will write the superior rectus, medial rectus, inferior rectus. And on the lateral aspect, the top muscle is inferior oblique, not superior oblique. Okay, it is inferior oblique and you have the superior oblique below. Now we look at the actions. So what is the action of superior rectus? It is going to have 3 actions. This is the action of medial rectus. The inferior rectus will have 3 actions. The superior oblique will have 3 actions. You have to draw the arrows like this. Okay, and there is one lateral rectus here. This is action. So medial rectus and lateral rectus have only one action. What is the action of medial rectus?
Adduction.
Adduction.
So medial rectus is only for adduction. Okay. Lateral rectus is only for
Abduction.
Adduction.
Now we look at superior rectus. Tell me what are the actions of superior rectus? 3 actions are there. What is this action?
Elevation, adduction,
Adduction.
Adduction is there. What is this movement?
Intorsion.
This movement is intorsion. This is the intorsion. The eyeball is moving medially. 12 o'clock position is moving medially. So that is intorsion. So that is the actions of superior rectus. Now tell me the actions of inferior rectus.
Elevation.
Depression. Adduction and extortion.
Adduction. Extortion.
And extortion. Yes, very good. Now tell me the actions of inferior oblique.
Elevation.
elevation,
Abduction.
Extortion. Abduction, elevation, extortion.
Extortion. Very good. Yes. And what is the action of superior oblique?
Intorsion.
First tell me.
Depression.
depression, abduction, intorsion.
Intorsion. Okay. If you draw this diagram, it will be very easy. But you should not make a mistake where you're going to label these structures. Okay. മനസ്സിലായി എപ്പോഴും ആൾക്കാർ തെറ്റിക്കുന്നത് ഇവിടെയാണ്. superior oblique മുകളിൽ എഴുതും, ശരിയല്ല. inferior oblique ആണ് മുകളിൽ എഴുതേണ്ടത്. Okay. superior oblique താഴെ എഴുതണം. Now I'll ask you another question. Which all muscles are the intorters?
Superior rectus.
Superior rectus, and
Oblique.
so the superiors are intorters. Okay, so this is another easy way to remember. Superiors are intorters. And what about the extorters?
inferior oblique,
Inferior rectus.
Inferior oblique.
So inferiors are extorters. You can look at each muscle and say which all actions it has, or you can look at each action and tell which all muscles help in each action. For everything, you need this diagram. This diagram is very, very important. So that is about the actions. What is this person doing? This student is copying from this female. So which muscle is he using? You are looking downwards and laterally. Your depression and abduction. ഈ അയിലെ ഏത് മസിൽ ഉപയോഗിക്കുന്നത്?
Superior oblique.
Superior oblique. Superior oblique is depression and abduction. Okay. So which muscle? ഈ കണ്ണോണ്ടല്ലേ നമ്മൾ കോപ്പി ചെയ്യാം.
Superior oblique.
So superior oblique is the copying muscle. Okay. The muscle that helps all of you to copy. That is your oblique muscle. So copying muscle is superior oblique muscle. Now we have to look at the axis of the muscles. Okay. So we saw there is only one action for medial rectus and for lateral rectus, and they lie in the same horizontal plane. Okay. So they will have the same axis as that of the optical axis. What is the optical axis? This is the optical axis. From the anterior pole to the posterior pole of the eyeball, this is the optical axis. So medial rectus and lateral rectus, the pull is in such a way that the plane is same as that of the optical axis. So what about superior rectus and inferior rectus? This is the superior rectus, and below we have the inferior rectus. So what is the axis? It is not same as that of the optical axis. It is 25 degrees lateral to the optical axis. Can you see in this diagram? It is 25 degrees lateral to the optical axis. And what about superior oblique and inferior oblique? See the superior oblique, and this is the insertion of pull of superior oblique. This is the line of. So what is the axis? It is 50 to the optical axis. Okay, they can draw this. So it is 51 degrees. This is of the optical axis. Superior 25 degree lateral. Now we have to see this muscle which is inserted to the eyelid, upper eyelid, and that muscle is called
Levator palpebrae.
It is seen above the superior rectus muscle. It is going to elevate the upper eyelid. Okay, that is the action of levator palpebrae superioris. What about the nerve supply of levator palpebrae superioris?
Oculomotor nerve.
Yes, which branch of oculomotor? Upper branch or lower?
Upper division of upper
branch.
Yes, upper division is going to supply superior rectus, then it will supply levator palpebrae superioris. Now we have to see, so nerve supply we saw, action we saw. Now we have to look at the origin and insertion. So tell me the origin of levator palpebrae superioris. Here you get the levator palpebrae superioris. From which bone? So it is taking origin from the undersurface of the lesser wing of sphenoid above the common tendinous ring. Okay, there is a medial border, straight medial border. There is a concave lateral border, and this lateral border separates. This part is orbital part, and this part is palpebral part. So orbital and the palpebral part is separated by the lateral margin of the levator palpebrae superioris. Then, if you look at this diagram, this sagittal diagram, you can see this is the levator palpebrae superioris, and it is dividing into 3 lamina. There is an upper lamina, there is an intermediate lamina, and there is a lower lamina. So the upper lamina, it is going to pierce this muscle. Which is this muscle? Orbicularis? Oculi. So it is going to, the upper lamina is going to pierce the orbicularis oculi, and where is it inserted? Onto the skin of the eyelid. Then the intermediate lamina, you can see this is the intermediate lamina, that is inserted in the superior tarsal plate. So this is the intermediate lamina, it is inserted to the upper border of the superior tarsal plate. And this intermediate lamina is otherwise called the superior tarsal muscle or the Muller's muscle. So this intermediate lamina alone is called the superior tarsal or the Muller's muscle, and that alone gets the sympathetic supply. Whereas the rest of the levator palpebrae is supplied by the third nerve, upper ramus of the oculomotor nerve. This alone, the Muller's muscle alone, is supplied by the sympathetic nerves. Then you have the lower lamina, and the lower lamina is inserted in superior fornix of the conjunctiva. You remember the angles were called fornix. Okay, so superior fornix of the conjunctiva. For insertion, there are 3 lamina. The upper lamina pierces the fibers of orbicularis oculi and inserted nerve skin. Then the intermediate lamina is otherwise called superior tarsal muscle or the Muller's muscle, and it is inserted in the superior tarsal plate, and it is supplied by the sympathetic nerves. And the lower lamina is inserted into the superior fornix of the conjunctiva. Okay, levator, palpebrae, superiorus can be asked as a separate short note. Now tell me which all muscles. What is this A? That is going to the upper eyelid only.
Levator.
That is the levator, palpebrae, superior. What is B? B ഏതാ ഈ മസിൽ ഇങ്ങനെ വന്ന്
Oblique muscle.
oblique muscle. What is C?
Superior.
What is D?
Medial rectus.
It is not medial rectus. It is lateral rectus. ഇവിടെയാണ് medial. അപ്പൊ this is
Lateral rectus.
muscle. E is
Inferior rectus.
muscle, and this is the
Inferior.
so all the recti muscles are inserted onto the sclera in front of the equator, and all the oblique muscles are inserted onto the sclera behind the equator, postero superior quadrant. Yes, okay. So this is another dissection view. This is a superior rectus, medial rectus, lateral rectus, inferior rectus. You can see the superior oblique change in direction for going for insertion, and this is clearly you can see the inferior oblique muscle. Okay, from the floor it is taking origin from the orbital surface of maxilla and inserted onto the postero superior quadrant of sclera behind the equator. The involuntary muscles, you know how many, which are the involuntary muscles? Superior tarsal, inferior tarsal, and orbitalis muscle. So superior tarsal muscle is the intermediate lamina of the levator palpebrae superior, that we already saw. And the inferior tarsal muscle is seen over here, attached to the inferior tarsal plate. And orbitalis muscle is seen on the floor of the maxilla, covering the infraorbital groove. And all these muscles are supplied by the sympathetic fibers. Okay, so superior tarsal is very important. It is otherwise called the Muller's muscle. Okay, this is the superior tarsal muscle. This is the Muller's muscle and supplied by the sympathetic nerves. So you can see levator palpebrae superior has got 2 supply. One is by the oculomotor nerve, and also by the Muller's muscle alone is supplied by the sympathetic fibers. So it has voluntary muscle fibers and involuntary muscle fibers also, the levator palpebrae superiorus. Now we look at some clinical condition. What is this condition? What is happening to the eye? You can see this eyelid, partial drooping of eyelid. Right? What is drooping of eyelid called? Yes, very good. It is called ptosis. Okay, so there is a partial ptosis. So this condition is caused because the Muller's muscle is paralyzed. That is, the sympathetic fibers alone are affected. So in which condition will the sympathetic fibers affected? Do you know any condition? So this condition is called the Horner's syndrome. So in Horner's syndrome, you get partial ptosis, and that is because of the paralysis of Muller's muscle matra. Levator palpebrae superiorus is not paralyzed. Okay, that is supplied by the third cranial nerve. So that if third cranial nerve is intact, but only the sympathetic fibers are lost, okay, that is seen in Horner's syndrome, you get partial ptosis. So only the Muller's muscle is affected and you get partial ptosis. So what are the other symptoms of Horner's syndrome? Horner's syndrome is affecting one side. There will be ptosis of that side. Okay, ptosis will be that. Meiosis. What is meiosis? Cell division meiosis. Meiosis. Look at the spelling.
Muscle.
What is meiosis?
Constriction of
Yes, you can see the constriction of the pupil, right? So you can see here the pupil is constricted. Constriction of pupil is known as meiosis. Then there is enophthalmos. What is enophthalmos? The eyeball has gone inside. Exophthalmos is what? The eyeball is bulging outwards. Enophthalmos is the opposite of that. Okay, the eyeball has gone receded backwards in the orbital cavity. Okay, so that is enophthalmos. Then there is anhidrosis. What is anhidrosis? Loss of sweating in that half of the face. Okay, that half of the face, that will be anhidrosis. That will be loss of sweating. Then there is one more symptom of Horner's syndrome, and that is loss of ciliospinal reflex. What is the ciliospinal reflex? That is something which is normal. If you pinch the skin of the neck region, and there will be sudden constriction of the pupil. Okay, so that is a reflex that is normally seen, and that reflex will be lost. So there are 5 symptoms for Horner's syndrome. What are they? This is very important. Ptosis will be there, meiosis will be there, enophthalmos will be there. So all these are related to the eyeball. Okay, ptosis, meiosis, and enophthalmos. Anhidrosis, that is loss of sweating in that half of the face, and there will be loss of cerebrospinal reflex in that side, on the right side. And you should remember the doses is only partial doses, not complete, and that is because of the paralysis of Muller's muscle alone. Now, what about this? There is complete drooping of the upper eyelid, and that is known as complete ptosis, and that is seen when the levator palpebrae superioris is completely gone. So that is when the third nerve palsy is there. Okay, so when there is third nerve palsy, you will get complete ptosis, and when there is Horner's syndrome, you will get only partial ptosis. Okay, that is because here the complete muscle is gone. Here the complete levator palpebrae superioris is lost to supply. So there will be complete drooping of upper eyelid. But there in Horner's syndrome, only the sympathetic fibers are affected. So only Muller's muscle will be affected. So only partial ptosis. Now we'll go to what is strabismus. What is other common term for strabismus?
Squint.
Yes, squint. In strabismus, what happens? The patient will see like this. There will be diplopia. What is diplopia? Diplopia is known as double vision. So you can see all the letters are seen as double. The patient will complain of diplopia. So these are the two types of squint. So this eyeball is normal. This eyeball has gone inwards. Okay, so this is known as top diagram. Squint will be called internal squint. Okay, so this is the internal squint, and this diagram you can see this eyeball is normal, but the left side eyeball has gone outwards. So this squint is called external squint. So these are the two types of squint. That is internal squint and external squint. So why will you get diplopia in these two conditions? If it is internal squint or external squint, you can get diplopia. The image of an object is falling through this pupil into the retina of this eyeball. Similarly, the image is falling onto the retina of this eyeball. But will the image fall on the same points on both the retina or different points?
Different points.
Different points, because the direction in which the light is passing is different, right? Because the muscles are paralyzed and the eyeball is not kept in the correct position, the image is going to fall on different points on both the eyeball. That is why the patient is complaining of diplopia. So in which condition will you get internal squint? Which condition will you get external squint? Internal squint, is it the lateral rectus or the medial rectus that is paralyzed for this eyeball?
Lateral rectus.
Lateral rectus. If the lateral rectus is paralyzed, the medial rectus will overact and it will pull the eyeball to the side. So it is the lateral rectus that is paralyzed to get an internal squint, because then there will be overaction of medial rectus. Medial rectus will pull and the eyeball will shift medially. So which muscle is paralyzed in internal squint? Lateral rectus is paralyzed. Now tell me about external squint. The eyeball has been pulled to this side. The muscle is paralyzed.
Medial rectus.
So if the medial rectus is paralyzed, what will happen? This side in the pulli anala sadhanam poi. There will be overaction of lateral rectus muscle. In external squint, there will be paralysis of medial rectus muscle. Now we have to see what are the features when there is paralysis of third cranial nerve, when there is paralysis of fourth and sixth. Okay. So when there is third cranial nerve palsy, we already parnyo. What is this? There will be
complete ptosis.
Complete ptosis. Okay. So there will be complete ptosis. Then we have spin oculomotor palsy. Oculomotor nerve palsy, which muscle is paralyzed? Medial rectus or lateral rectus? Medial rectus. So medial rectus is paralyzed. So you can see this eyeball, compared to this eyeball, it is outwards. Okay. So there is which squint?
External squint.
There will be external squint. Now look at the pupils. So if you open this eyelid and if you look at the pupil, what are you going to see? If this side is paralyzed, this nerve is paralyzed, the pupil has been dilated. Okay, so there is fixed and dilated pupil of that side. And there is loss of accommodation. So fixed and dilated pupil, loss of accommodation. Then there is an apparent exophthalmos. Okay, that is as the eyeball has protruded out. It looks like that. And there is diplopia. Diplopia will be there in every condition. It's all the nerve palsy, 3, 4, 6 ayalum, there will be diplopia in all the conditions. So we saw the reason for complete ptosis. Due to the paralysis of which muscle?
Levator palpebrae superioris.
External squint is because of the paralysis of which muscle?
Medial rectus.
Medial muscle.
Yes. So that is medial rectus. Now what is the reason for dilated pupil, fixed and dilated pupil? So sphincter pupil is receiving the parasympathetic supply via the oculomotor nerve, via the branch to inferior oblique. The parasympathetic fibers are going to pass, and through the branch to inferior oblique, that is going to supply the sphincter pupillae muscle. Okay, sphincter pupillae of the muscles of the iris. Okay, sphincter pupillae. So sphincter pupillae muscle is receiving the fibers from the oculomotor nerve. When this oculomotor nerve is paralyzed, this muscle will be paralyzed, and you will get dilated pupil. You will get fixed and dilated pupil. Then accommodation. accommodation help ചെയ്യുന്ന muscle ഏതാണെന്നറിയോ? Again, it's a muscle of the eyeball. Intraocular muscle. Okay, not extraocular muscle. These two are intraocular muscles. This is ciliaris muscle. Ciliaris muscle and sphincter pupillae are supplied by the parasympathetic fibers via the oculomotor nerve. And when this muscle is affected, there will be loss of accommodation. What is accommodation? So you are able to focus something which is in the distant view. And when that object comes very near to you, you can still focus the object clearly, right? So the ability to shift that focus from a far object to a near object, that is known as accommodation. And which is the muscle responsible for accommodation? Ciliaris muscle. So when that muscle is paralyzed, you will get loss of accommodation. Then why is there apparent exophthalmos? All the extraocular muscles except superior oblique and lateral rectus is supplied by the oculomotor nerve, right? So all the other muscles are paralyzed. So when most of the muscles of the eyeball are paralyzed, the eyeball will become loose. Okay, so it will look like as if it is protruded. Okay, apparent exophthalmos. And what is the reason for diplopia? I already told you, because the image is not falling on the same point on both the retina. So these are the features of oculomotor nerve palsy. This is very, very important. This is the diagram I wanted to explain. So you have the ciliary ganglion in the orbit. It is a peripheral parasympathetic ganglion and it has three roots. You have the parasympathetic root, you have the sensory root, and this green is the sympathetic root that is passing through the ciliary ganglion. So explain the parasympathetic root. It is starting from which nucleus? From this nucleus, Edinger-Westphal nucleus. Okay, what is the nucleus? Edinger-Westphal nucleus in the midbrain. From there, the fibers are going to arise. The parasympathetic fibers are arising. These fibers are going to pass through the oculomotor nerve. Okay, this is the third cranial nerve, through the branch to inferior oblique. And they're going to relay in the ciliary ganglion. Then the postganglionic fibers will arise from the ciliary ganglion, pass through the short ciliary nerves, and it will go and supply which muscle? Parasympathetic fibers are for which muscle? Sphincter pupillae, constrictor pupillae, and the ciliaris muscle. Okay, two muscles are supplied by the parasympathetic. One is constrictor pupillae, and the other one is ciliaris muscle. So when there is oculomotor nerve palsy, this nerve is gone. The fibers will be affected. So there will be paralysis of constrictor pupillae and paralysis of ciliaris muscle. So there will be a fixed and dilated pupil, and there will be loss of accommodation. So the ciliary ganglion, it is topographically, it is related to which nerve? Topographically means geographically. Okay, it is seen related in close to which nerve in the orbit?
Nasociliary nerve.
Very good. It is topographically related to nasociliary nerve. But functionally, that is which fibers are passing through the ciliary ganglion? Fibers of third nerve. The oculomotor nerve. So oculomotor nerve is functionally related to ciliary ganglion. So ciliary ganglion is topographically related to nasociliary nerve, and functionally it is related to the oculomotor nerve. What about the sensory fibers? These are the yellow is the sensory fibers. The sensory fibers are going to arise from the eyeball. It is carrying the pain, touch, temperature sensations from the eyeball. It is passing through the short ciliary nerves and the ciliary ganglion without relay, and it is passing through which nerve? Nasal ciliary nerve. It is carried to the central nervous system. Then sympathetic fibers are green. These green fibers. Green fibers endana? They are arising from the T1 segment of spinal cord. They are going to relay in the superior cervical sympathetic ganglion. Postganglionic fibers will arise. It will form a plexus around the internal carotid artery, and these fibers will pass through the ciliary ganglion without relay, and it will supply the which muscle? The sympathetic is going to supply which muscle? It is supplying the dilated pupil. So that is the connections of the ciliary ganglion. This is very important. Okay. Now we look at the trochlear nerve palsy. Which muscle is paralyzed in trochlear nerve? Superior oblique muscle. So what will be the symptom? There will be diplopia on looking downwards and laterally. It helps in looking downwards and laterally. So only when you look in that direction, there will be diplopia. Otherwise, if you look normally straight ahead, there will be no problem. Only when you try to copy, there will be diplopia. Okay. So those who have this trochlear nerve palsy cannot do copying. Okay, copying becomes difficult. Okay, now we'll see the abducent nerve. What about the abducent nerve? What will be the symptoms?
Internal squint.
There will be internal squint. Okay, convergent squint, there will be internal squint because the lateral rectus is paralyzed and the medial rectus will overact. And there will be internal squint, and there will be diplopia. In all the conditions, there will be diplopia. And this is very important. That is, abducent nerve is the most commonly paralyzed due to raised intracranial pressure. So when there is a raised intracranial pressure within the cranial cavity, the first nerve to be paralyzed will be your abducent nerve. What are the reasons for that? That is very important. It is having a long intracranial course. Okay, so it is having a long intracranial course. Then another cause is It is having a sharp bend over the upper border of Peter's part of temporal bone. Coming from the brainstem, then it is going to pass through the as a content of cavernous sinus. So before that, there is superior border of Peter's part of temporal. There is a sharp bend, so it can easily be stretched over there. Then there is one more reason. When there is raised intracranial pressure, what happens is the brain stem will descend down through the foramen magnum. It will descend down. Abducent nerve will be stretched. So these are the three reasons for the abducent nerve palsy. One is it is having a long course. Intracranial course is very long. Then it has a sharp bend over the superior part of the Peter's temporal bone. And when there is intracranial pressure, the brainstem will descend down through the foramen magnum. That time this nerve will be stretched. Okay. Then what is this condition? Cavernous sinus thrombosis. So which is in the lateral wall, which all nerves will you see? Which is this nerve? Oculomotor nerve. Then you get the trochlear. Then which is this nerve? 5-1. What is 5-1? Ophthalmic division of fifth cranial nerve. Which is this nerve?
Maxillary.
Yes, maxillary division of fifth cranial nerve. That is 5-2. Yeah. Second division of fifth cranial nerve. That is maxillary division. Then what is this nerve? As a content?
Abducent.
So 3, 4, 6 all are affected when there is cavernous sinus thrombosis. And when these 3, 4, 6 nerves are affected, what will happen? What is that condition called? You're not able to move any of the extraocular muscles. You're not able to move your eyeball at all. So that condition is called?
Ophthalmoplegia.
Yes. That is called ophthalmoplegia. Okay. So one of the symptoms is ophthalmoplegia. Then because of ophthalmic division of the trigeminal nerve is affected, all the nerves to the orbit are affected. Like nasociliary, frontal, lacrimal, all these nerves are affected. So what will be the symptom? There will be pain, severe pain in the region of the eye and forehead. What will be the third symptom? What are the tributaries of the cavernous sinus from the eyeball? There is superior ophthalmic vein, there is inferior ophthalmic vein, and there is
Central vein of retina.
central vein of retina. Very good. So these three veins, so the superior ophthalmic vein and inferior ophthalmic vein are the veins that are draining the blood from the orbit. When there is cavernous sinus thrombosis, these veins cannot drain properly into the cavernous sinus. So there will be congestion of the venous blood, and that will result in exophthalmos. So what are the three features of cavernous sinus thrombosis? There will be ophthalmoplegia because 3, 4, 6 nerves are affected. The eyeball is not able to move. Then because the nerves of the orbit, ophthalmic division is affected, there will be pain in the region of the eye and the forehead. And because the venous blood is not able to drain properly, there will be congestion of the venous blood and there will be exophthalmos. So that is about cavernous sinus thrombosis. Now I'll ask you a few questions. Okay. Select the incorrect statement about the levator palpebrae superiors. Supplied by oculomotor nerve and cervical sympathetics. Is it true or false?
True.
Yeah, it is supplied by both oculomotor nerve and the superior tarsal muscle is supplied by, or the Muller's muscle is supplied by cervical sympathetics. And its paralysis causes ptosis. Is it true or false?
True.
True. Causes complete ptosis, right? Then consists of both voluntary and involuntary muscle fibers. Is it true or false?
True.
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 True. Then it arises from the undersurface of the greater ring of sphenoid near the apex of orbit.
False.
Yes.
What is the answer?
Lesser wing.
It arises from the lesser wing. Yes. Good. All muscles are supplied by oculomotor nerve except
Superior oblique.
Superior oblique.
superior oblique, which is supplied by
Trochlear.
trochlear nerve, the fourth cranial nerve. Okay. Which nerve is seen outside the common tendinous ring?
Trochlear.
Trochlear nerve. Yes, very good. LFT is through the supralateral compartment. Ona is through the intermediate, through the common tendinous ring. So it is the oculomotor nerve, nasociliary nerve, abducent nerve will all pass through the common tendinous ring. Trochlear is outside. Okay. All bones are part of the floor of orbit except. What are the bones forming the floor of orbit?
Ethmoid.
Yes, it is the ethmoid bones. What are the bones forming the floor of orbit? Orbital surface of maxilla. പിന്നെ
Orbital surface of zygomatic.
orbital surface of zygomatic bone. പിന്നെ backല് small area orbital process of അത് process ആണ് orbital process of palatine bone. Yes. So ethmoid will not come. Ethmoid will come in which wall of orbit?
Medial wall.
Yes, very good. Medial wall of orbit. Okay. Then wrong statement about the walls of orbit.
Roof is formed by lesser wing of sinus.
Yes, roof is formed by which wing?
Lesser.
Lesser wing. So roof is formed by which all bones?
Orbital surface of
Frontal one.
So orbital surface of condyle bone വരും. പിന്നെ
Lesser wing of
lesser wing of
Sphenoid bone.
lesser wing of sphenoid bone വരും. Okay, that is two structures forming the roof. Then tell me about the medial wall. How many bones are forming the medial wall?
4 bones.
Four bones.
In orderly പറയണം. Orderly എന്താ?
Frontal process of
maxilla,
lacrimal bone,
lacrimal bone, പിന്നെ
orbital plate of ethmoid,
yes, orbital plate of ethmoid.
body of sphenoid.
Yes, very good. Body of sphenoid. Very good. What about lateral wall?
orbital surface of zygomatic bone.
The orbital surface of zygomatic bone.
Orbital surface of greater wing of sphenoid.
Yes, very good. By the greater wing of sphenoid. Floorലാണ് 3 bone. That is maxilla, orbital surface of maxilla, പിന്നെ orbital surface of zygomatic bone, പിന്നെ
Orbital process of palatine.
orbital process of palatine bone. Medial wall of the orbit is formed by all the bones except.
Lesser
Lesser wing of
It is
sphenoid.
forming part of what?
roof.
It is forming part of roof. Yes. So what is lamina papyracea?
Orbital plate of ethmoid.
Very base. It is the orbital plate of ethmoid bone is otherwise called lamina papyracea. What is the reason for that? What is the word meaning of lamina papyracea? It is like a paper thin. Papyracea means like paper thin. Okay, so it is very thin plate of bone. This ethmoid bone is very thin plate of bone. It is forming a part of the medial wall of orbit and it is separating the orbit from ethmoidal air sinuses. So what happens? Easily an infection can spread from the ethmoidal air sinus to the orbit or otherwise from the orbit to the ethmoidal air sinus. അങ്ങോട്ടും ഇങ്ങോട്ടും infection can spread because it is very thick. The orbital lamina of ethmoid bone is very thin. So it is called lamina papyracea. Paper thin ആണ് ഈ papyraceയുടെ meaning. Which muscle produces intorsion of eyeball?
Superior rectus and superior.
Superior rectus and superior oblique. We saw the superiors are intortus and inferiors are extortus. Take your time, draw the diagram and see which is the correct answer. Incorrect statement about ciliary ganglion?
Third one.
Lies between the optic nerve and medial rectus. Allah. It is lying between the optic nerve and the lateral rectus. Functionally connected to oculomotor nerve and topographically it is connected to nasal. Okay, so this is the diagram to show you the ciliary ganglion. Here you get the ciliary ganglion between the optic nerve and the lateral rectus muscle, close to the apex. This is the nasociliary nerve. It is topographically to nasociliary nerve, but the fibers that are passing through the ciliary ganglion will be that of oculomotor nerve. A patient is unable to move the eye outward beyond the midline. The lesion is in? Yes, it is lateral rectus that is paralyzed. So it is the abducent nerve. Action is lost. Okay. Oculomotor nerve palsy causes all except.
Medial deviation.
Oculomotor nerve causes what? It causes external squint, lateral deviation. Medial rectus paralyzed eye. So, overaction of lateral rectus. So, there will be lateral deviation of eyeball. The answer is medial deviation. What is mydriasis?
Dilation of
Dilation of pupil വിളിക്കുന്നതാണ് mydriasis. Constriction of pupil വിളിക്കുന്നതാണ്
meiosis.
meiosis. So, mydriasis is opposite meiosis. Okay. Paralysis of which muscle causes dilation?
Sphincter pupillae.
Sphincter pupillae. Very good. So, that is about today. Thank you.